pediatric presenter, and so we're very delighted to have Dr. Jan Lee presenting with us today. He's a senior consultant at the Children's Intensive Care Unit at the KK Women's and Children's Hospital in Singapore. He holds an academic rank of assistant professor at Duke NUS Medical School at Singapore. So thanks very much, Dr. Lee.
Very good morning, distinguished colleagues, and thank you, Mr. Chairperson. And thank you for coming to this session. Over the next 25 minutes or so, I'll be talking about our experience in Asia with regards to Pediatric Acute Respiratory Distress Syndrome, or PARDS, or PARDS for short. And I want to thank the scientific committee for giving me this opportunity to share some of the work that we've been doing over the past 4 to 5 years. So I have no conflict of interest for this presentation. And really, over the next 20 minutes, I'll be focusing on 2 main points. I'll tell you a brief history and the progress that we've made in Asia in establishing a sustainable research network, and that is known as PACMAN, a Pediatric Acute and Critical Care Medicine Asia Network. And after that, I'll be really focusing on the work that we've done in PARDS in Asia. So about 5 to 6 years ago, my team and I, back in our hospital at KK Women's and Children's Hospital in Singapore, conducted a small retrospective study of about 70 patients across 4 years with PARDS. And we were somewhat humbled by our findings, and you can tell from the table shown here that we have about 70 patients, and about 60 to 70% of our patients died during that period. And initially we thought Singapore was a modern, advanced country, but we were somewhat humbled by the numbers that we found. And this table just showed that the non-survivors have, patients with more multi-organ dysfunction, and they have, more often have presence of comorbidities in our children. So what did we learn from this small study? We realized that by doing it ourselves, we are somewhat limited by the small numbers within a single center. As mentioned, our mortality rate at that time was very high, and so we asked ourselves, can we improve our outcomes? And finally, we wanted to ask, we asked ourselves, is our experience similar in other countries within the same region, and especially within Asia? So to address that, actually, my team then went on to try to look at the literature to see what, is being currently described in terms of epidemiology. And as we were doing this, we were, taken aback because someone from the Netherlands actually overtook us and published their findings on systematic reviews in PARDS. But nevertheless, we persisted, and we also, and I'll share some of the findings in our systematic review. So there are currently two systematic reviews with regards to PARDS in the literature. And the one from the Netherlands, their aim were to estimate the population incidence of PARDS and to estimate the mortality. And they looked back over the past 20 years, and they included both retrospective and prospective studies. They came up to about 29 to 32 studies, depending on the outcome they were looking at. And for our own review, we wanted to really describe, has mortality changed in PARDS over time? And we looked back all the way about 50 years ago, and we included only prospective study and only included studies that have more than 20 patients. So based on the review done by the group in Netherlands, PARDS is indeed not a very common diagnostic criteria or diagnosis that we find in our PICS ICU, and it only makes up about close to 2% of our admissions. And in their review, they found that the overall mortality was about 34% and PQ mortality about 26%. Interestingly, when they look at the the type of studies or the origin of studies based on the countries, the Western countries in overall mortality was about 27%, with a confidence interval of about 22 to 34. But interestingly, in Asia, the mortality was twice as high compared to the Western countries, and that was closer to our own single center numbers, which is about 51%. So they concluded, or they found that there are higher mortalities performed in Asia. And interestingly, they mentioned that there was no change in mortality over time in Asia. They also looked at the type of study design, and they did not find any difference between different study design. How about for our own systematic review? The world map shows that the numbers of observational and randomized control trials done in PARDS You can see from the world map that majority of the studies were conducted in North America and Europe, with really small studies originating from Asia and the Pacific. The forest plot shows in chronological order the studies that was performed in PITS ARDS, and you can tell that actually we are, or at least the mortality in PITS ARDS is improving over the years, 0.94 odds ratio over time. And again, we found, similar to the previous systematic review, there was no difference in mortality between observational and randomized controlled trials. So what did we learn? At least from our own, from the two reviews, we found that in Asia, single-center studies predominate. And when there are multi-center studies, they are mainly limited within a single country. And indeed, there was a lack of pediatric critical care collaboration and teamwork within Asia. And based on the difference in mortality, epidemiology and data from Asia may indeed be different. So that sort of started our journey or our work to establish a network where different centers across Asia can come together. And over the next few slides, I really want to go through how we have taken several small steps to establish PACMAN. So the effort really started about 4 years ago, back in 2014, in May, during the World Congress of the Pediatric Intensive and Critical Care in Istanbul. And during that time, we met our two collaborators from Vietnam and Thailand. And they were presenting on PITS ARDS as well, and we actually found similar mortality rate in Singapore and Vietnam and Thailand. And so after that conference, we kept in touch. We completed the single-center study that I mentioned earlier, and we started discussion about the possibility of doing a multi-center PITS ARDS study. So we sent out some preliminary survey to certain sites to ask for interest and to see whether they were keen to join us. A few months later, we started to construct an online database so that sites across Asia can easily enter their data, and we sought ethical approval from Singapore and the various sites that were interested. And because this is a multi-center collaboration, we needed a center that had experience doing this type of work. We established some partnership with the Singapore Clinical Research Institute to help us with the database. And throughout the year, we continued to recruit sites. Another site from Singapore joined us, a site from China, and a site from Malaysia. So we continued to engage the sites. In April 2016, we managed to get a small grant, about 30,000 Aussie dollars. And really, the first informal meeting to moot the idea of PACMAN happened at the next World Congress in Toronto. And we asked the Asian delegates to meet. It's really quite far away for Asia to meet over there, but nevertheless, those who attended the meeting, we went out and met together. And really, after that meeting, even about more than six to eight sites expressed interest and joined us after that meeting. And really, we throughout that year, since the starting of the online database, sites that have expressed interest started to put in the data on PITS ARDS. And really, the fruits of our labor were, seen in January 2017, where some of our young researchers actually presented some of the work that or the findings that we had in the Critical Care Congress held by the Society of Critical Care Medicine in the US. And in April 2017, we finally held our first PACMAN meeting in Singapore, and you can see that those in the photo are the pioneer members of our PACMAN group. So over the past year, we continued to use the data that we've collected to look at various aspects of PITS ARDS, and I'll be presenting some of the data that we have later on. And really, the PACMAN group members were really very happy when our first manuscript on the risk stratification in PITS ARDS was published in Critical Care Medicine. Moving ahead, we firm up, or we try to establish or get further grants for other aspects of pediatric critical care. So we just recently secured funding to do studies in pediatric traumatic brain injury. And the last World Congress in Pediatric Critical Care was held in Singapore just June this year. And we held our second meeting, and you can see that the number of people interested in PACMAN has grown since the first meeting. So I shall move on to the next focus of my presentation, really to look into the epidemiology of PEDS ARDS in Asia, and that was done through the PACMAN research network. And so one of the first things that we have done as a group is really to validate the PALIC's definition. And the PALIC is actually the Pediatric Acute Lung Injury Consensus Conference. A team of experts actually met in 2015 to come up with a PEDS ARDS definition. And unlike the ARDS definition in adults, the first PEDS definition was only established 3 years ago. And so, since that definition was fairly new, there was no real validation of that definition. And so, as a group, we wanted to see whether this new definition is indeed robust. So, we conducted a multi-center retrospective cohort study across 10 centers: China, Thailand, Vietnam, Malaysia, and Singapore. And we collected data retrospectively from 2009 to 2015. And all patients were followed up to 100 days after diagnosis. And because the definition focuses on patients on mechanical ventilation, we only included patients who were on invasive ventilation. So over that 5-year period, we actually collected close to 380 patients, and the definition actually classified them somewhat similar to the Berlin definition, to mild, moderate, and severe PEDS ARDS. And you can tell from this table that children with severe ARDS has a higher PIM2 and PLOT score, as well as their oxygenation index was much worse. And our PICU mortality, at least from this 5-year data, was 30%. And if you look at our 100-day mortality, was close to 40%. So this survival curve shows good separation between the 3 groups of ARDS as defined by the PALIC consensus group. And even after adjusting for site presence of comorbidities and how sick the children were, we showed that the moderate patients or children with moderate ARDS had twice or 2.5 times higher mortality, and those with severe PEDS ARDS had close to 4 times higher mortality. So we look at a few secondary outcomes, including ventilator-free days as well as PICU-free days, and you can tell that the group with severe PEDS ARDS are not doing so well. We also took the opportunity to look at the mechanical ventilation settings that our patients were on. And this table shows the ventilator settings on the first day of PEDS ARDS. And you can tell that children with severe PEDS ARDS were supported with alternative modes of ventilation, such as APRV and high frequency. And despite the recommendation by the PALIC group to recommend lower ventilation strategies in children with severe PEDS ARDS, we were not doing what we thought we were doing, and children with severe PEDS ARDS were still exposed to fairly high peak inspiratory pressure. And significantly, there was no difference in tidal volumes that we were giving our children. And across mild, moderate, and severe, we were giving close to 9 to 10 mL per kilo, and there was no difference across the groups. So in terms of what were we targeting in terms of gases exchange in these children, again, this table shows that, really those with severe PEDS ARDS, we were achieving lower oxygen arterial pressures as well as, lower saturations. But really there is no clinical significance, in terms of the pH that we achieve and the carbon dioxide partial pressure that we were trying to achieve in these patients. And these 4 graphs really show, that what we thought we were doing, we were really not really doing on the floor. So in terms of PaO2, our whole cohort, we were aiming for about 75, which is somewhat fairly high, especially for the severe PEDS ARDS group. And really a huge majority of our patients, had very good saturations, which may not be ideal in children with PEDS ARDS. And in terms of the carbon dioxide, we were really not really allowing permissive hypercapnia. And even in terms of pH, we were really targeting normal pH, where we should be really targeting, slightly lower pH. So perhaps this may suggest that, the way that we are ventilating our children are far from the recommendation, and perhaps, the next step is really to introduce perhaps bundle care in terms of ventilations to help maybe perhaps improve the outcome of ARDS in Asia. So because we had a huge data set, we took the opportunity to do some secondary studies, and we wanted to look specifically, whether children with extrapulmonary ARDS were indeed different from those with pulmonary ARDS. And we also wanted to take the opportunity to look at the use of high frequency in this group of children. So using the same data, we started off, about 440 patients, but as mentioned, we had close to 380 patients on invasive ventilation. And we looked through our data to just identify patients with one identifier main risk factors. And those, we excluded those with overlap risk factors, meaning those with both pulmonary and extrapulmonary ARDS. And we had about 266 patients with pulmonary ARDS and about 40 patients with extrapulmonary ARDS. So not surprisingly, a huge majority of patients had pneumonia as the inciting factor for ARDS. And really, non-pulmonary sepsis is the most common extrapulmonary cause for ARDS in our cohort of children. And so comparing the two groups, children with extrapulmonary ARDS had bacteremia more often, and they were indeed somewhat sicker in terms of higher severity scores. And the presence of multi-organ dysfunction were also higher in the group with PIDS, extrapulmonary ARDS. How about the outcomes? Well, if you look at the PICU mortality, the group with extrapulmonary PIDS ARDS had close to twice the mortality of those with pulmonary ARDS. And the other outcomes, such as the ventilator-free days and the PICU-free days, were also less. Right? This is two in the group with extrapulmonary PIDS ARDS. They only have 2 ventilator-free days compared to 19. And then this survival curve actually shows, that the group with extrapulmonary PIDS ARDS seem to be doing worse compared to children with pulmonary cause for the ARDS. However, after we adjusted for some comorbidity, some covariates such as severity scores and comorbidities, we found that the extrapulmonary PIDS ARDS was not a factor driving that mortality, and perhaps it is the presence of, the presence of multi-organ dysfunction or the presence of comorbidities that were driving the higher mortality that we have seen. So high-frequency oscillation has gotten a bit of bad press recently from the large OSCILLATE and OSCAR trials. And indeed, there are some smaller pediatric studies that showed potential harm in terms of if you supported children with PIDS ARDS on high-frequency ventilation. So because of that, my team and I decided that we should take a look at this closer using the data that we have. And what we did, and this was presented in the World Congress in June this year, using data that we had, we did a propensity score analysis, and we have about 1/3 of our children supported on high frequency and about 2/3 or 200 patients supported on conventional. And we used propensity score matching to match the likelihood of receiving high frequency in our cohort, and we managed to get 82 pairs of patients. So before matching, if you look at your left, the table shows that children supported on high frequency had higher risk of having comorbidities, and indeed their oxygenation index or their hypoxemia was worse before the matching. But after matching, these two factors became similar, and so we sort of overcome the confounding by at least comorbidities and OI. So these are the covariates that we included in our propensity score model, the important covariates such as how sick they were, presence of comorbidities, as well as the OI were included in our propensity scores. So after matching the two groups, we found that there was no difference in PICU mortality, and in terms of 100-day mortality, there was no difference between the two groups. And in terms of ventilator and ICU-free days, again, we did not find any difference in children supported on high frequency and conventional mechanical ventilation. And this data actually again supports that we at least in the pediatric population, that remains clinical equipoise. And for those who are in the pediatric community here, there will be a new trial coming up, Prospect, that will be looking at high frequency and prone positioning across multiple centers, and that's led by Martha Curley and her team from the US. So based on what we have found, or based on experience, I just want to go through the next few slides on future directions and to end off. So since the pioneer study on PIDS ARDS, the PACMAN sites have expanded from the original 10 to close to 20 sites currently, and we have sites from Singapore all the way to China and to Myanmar. And really, doing a multi-center study within Asia has their own challenges. And I think one of the main things that we faced were different national healthcare systems. And based on that, there are marked heterogeneity in terms of resources that we have across countries, and as well as clinical capabilities. So, for example, not every site had ECMO as a support for refractory hypoxemia for PIDS ARDS. Only 5 sites had such capabilities. And traditionally, sites in Asia are very focused on clinical service, and there are not many resources allocated to research. And I'm really very happy that the sites that joined us did a lot of this work without any funding, and really is based on their own site principal investigators' time and effort. As mentioned, with research infrastructure is not well established. A lot of these data that we have are collected by hand. And one of the sites, when we were conducting the study, mentioned that they have to delay entering the data because they have a major flood, and all the case notes were washed, and they have to get some time to collect those data again. And of course, language. I mean, most of the investigators across Asia speaks English, but sometimes it's better communicated in their native language, and through haste to make sure that the communication were efficient. Sometimes we have to end up using Google Translate to translate the whole email to Mandarin so that they can respond a bit faster. And finally, funding. Yeah, as mentioned, the PIDS ARDS study was really conducted with only about 30,000 Aussie dollars, somewhat small amount, but we were very happy that we were able to collect that amount of data and to use it for to look at our own data. So one of the main aims really is for PACMAN to look externally and to see whether we can engage other large research networks. And the engagement with international groups is indeed a priority for PACMAN. And I think the struggle, the challenge really is to identify areas of interest. At least for Asia, PIDS ARDS and severe pneumonia are very topical diseases, and they are very high in frequency and mortality. And really, this challenge really is for us to decide whether we want to look internally versus externally. I think given the economic climate now, many countries are trying to look internally, but as for PACMAN, we are really looking to learn from other larger research networks so that we can become more effective in Asia. We are looking also for mentorship from large critical care groups such as the NZICs, where they have many years of experience, as well as other networks in North America and Europe. And finally, in terms of collaboration, I think what's important is really not to do a single study and then just end there, but really to sustain the kind of relationship that we have between 2 networks. So with that, I would like to thank the collaborators who have worked with us. These are the 10 pioneer sites that established PACMAN. As mentioned, without their effort and their help, this work would not be possible. And of course, to the Singapore Clinical Research Institute and to my home institution, where they've given us the support that we needed to establish this network. And with that, thank you.
Thank you very much, Dr. Lee. It's an amazing amount of work, and congratulations to you and your investigators. Are there any questions? Dr. Ferrante?
Hi, I'm Lauren Ferrante from Yale. That was a great talk, and kudos to you for forming that network. That's amazing. I think the network has a lot of potential, both from a research standpoint, but also potentially from a quality improvement standpoint. And I wanted to ask you, the low or lack of low tidal volume ventilation seems like a great opportunity for some kind of coordinated quality improvement intervention throughout all of these different sites where you could implement an intervention and then still publish from it with an interrupted time series or something else, but really affect change through this network that you formed. And so I was wondering if you were pursuing, if there were any initiatives in the works.
Yeah, that's a great comment. And indeed, as we realize what we think we're doing is not being translated to the floor. And I think one of the challenges that we have in Asia is in the night or in the evenings or over the weekends, there are not many senior doctors, that are rounding. And really, they are the junior doctors or the nurses who are left manning the patients. And so probably active weaning or active adjustment of the ventilators do not happen as often as we would like to. And so we were discussing in terms of our own group to see whether we can introduce such like a bundle of a quality initiative to ensure saturation targets are lowered, tidal volumes are adhered to. And yeah, if we, that's a good idea and it's something that we'll be looking at to introduce such an initiative.
Dr. Shaw, I look forward to this question.
Thank you. Hey, look, wonderful work. What I think was one of the challenges that you face and those who work in adult medicine face is the lack of knowledge about what other people are doing. And the way we capture that knowledge is something I think we should all think about. One thing I've been thinking about is, in fact, capturing data electronically and sharing it on a cloud-based server. One of the things that struck me about your presentation is the driving pressures, say, in your pediatric ARDS for 18 centimetres of water. We know that, at least in adults, from that analysis by Marcello Amato, that's bad. Your PEEP seems to always be about 10. It's 10 in adults too. So there are a lot of things which you want to be able to study in terms of regional differences, and they'll be brought out by having a network that actually captures this information automatically, electronically, without imposing on people's time. I just wondered if you've been thinking about along those lines, because I think that we all need to do that.
Yeah. Thank you for your comment. Again, the electronic medical records or system are not consistent across Asia. At least in Singapore, both sites involved are electronically or they have electronic medical records. But I can't say that for sites in Malaysia and in Thailand. So we still would require some manual or a manual way of collecting those data, and that adds to the intensity of the data collection. And so some of the work that we are thinking about is to balance between how greedy we want in terms of getting as much data as possible and balancing it with whether it's feasible for sites that do not have electronic medical systems to help them to make it automated in a way. Yeah. But I think your comment on the ventilation data that we had, really we are using very low PEEP, high driving pressures, and even high tidal volumes per se. Yeah.
Yeah, thanks very much.
So thanks very much, Dr. Lee, and all the best for your future endeavours. I could imagine that it, like Dr. Ferranti said, that there's a great opportunity to do some work in this field, and now that you know that you have got sort of mortality of 40% in this particular age group, I would have thought it's a great opportunity to get funding to do some great work, so all the best with that.
All right, thank you.